Hello. Welcome to leadconnection.org podcast, where we talk about all things related to lead management. I'm Tom Callahan. I'm joined by Dr. Bruce Wilkoff and Dr. Paul Pottinger. You two want to take a moment to introduce yourself?
Sure. So I've been overseeing lead-related things for a long time at the Cleveland Clinic, and I hope you all know who I am. But Paul is a man that I met at another conference, and I think he has a perspective that we'll all enjoy. Paul, you want to explain where you're from and what you do in general?
Yeah, well, first of all, I'm not an electrophysiologist, so
Right, that's true.
I am a friendly infectious disease doctor. I'm Paul Pottinger, professor of ID at University of Washington in Seattle. I take care of patients who have concerns around general infections, and that does include infected devices, both endovascular, pocket infections, the whole gamut. And so happy to talk about that topic today.
And Paul's come all the way from Seattle here to Cleveland to join us for this. And I'm really excited about this because we need to look at things at different perspectives. And we have some great ID support here, but getting new information and maybe looking at things a little differently is important. What do you have to start us off with, Tom? Here?
Well, I mean, we're pleased to be joined by one of our infectious disease colleagues. So let's talk. Let's dive into infectious disease issues. So I think one thing that is a burning question for a lot of people, one thing that comes up often, is the question of antibiotic allergies, drug allergies, penicillin allergy in particular, and sort of how to navigate that issue in patients either for prophylaxis or treatment.
Yeah, I appreciate that question so much. What we know about prophylaxis is that you want to target the germ that's likely to cause the infection. And so one of the important workhorses in general, not only in EP, but I think in electrophysiology and device infection prevention, really is around getting a cephalosporin into those patients. Cefazolin is a first-generation cephalosporin. Some people call it cefazolin, I call it cefazolin, potato, but this is your first generation cephalosporin, and it's a great drug because it's quick, it's clean, it can go in very rapidly, and it also targets some of those big bugs that you're worried about in this situation. That's Methicillin staph aureus, that's a lot of gram-negative infections as well. Currently, people are worried about using this in the lab because about 10% of Americans are labeled with a penicillin allergy. I'm not going to say that they're allergic because of those 10% who believe they're allergic, 10% of them are truly correct. If someone tells you they're allergic to penicillin, there's a 9 out of 10 chance that they are just not right. They're not lying to you, they're just confused. They've been given false information, and that's a problem because if you're not sure whether something is safe to use, in general, someone's going to avoid using it just out of concern for patient safety, workflow, etc. Our colleagues in allergy medicine, the Quad AI Society, have decided that enough is enough. And they've looked over a period of years at a number of well-done trials, clinical evidence that is pretty convincing to say that, generally speaking, if we talk to patients who have a penicillin allergy label, we can very rapidly identify those who truly are allergic and should not get a cephalosporin, versus the majority who actually are completely 100% safe to have cefazolin, perhaps in addition to vancomycin. The key here is to have the conversation. Talk more, test less, use the best treatment.
See, that's really, that's impactful because, I can tell you it comes up very often, right? Where you talk to a patient, they report either a penicillin or usually penicillin, but sometimes a cephalosporin allergy, and you pump the brakes, right? You stop, but in your heart of hearts, you know that you could probably use some of these medicines for some of these patients.
That's right, and you want to go into that case feeling like you've done your due diligence, you've given them the best preventative antibiotics based on the best information.
And the data is better for cefazolin. I'll change. Well, the data is better for cefazolin than any other antibiotic, including, I remember some of the data from the RAPID study, but other studies as well, that cefazolin patients had fewer infections than the vanco patients. Although combined use may be the best of situations there, we just don't have the data right now. So if it's important to get the cefazolin in, what questions should we be asking? How do we go about doing that?
Well, there's an app for that. So we've built a web tool to help make this a very quick conversation. The concept is that based on these structured questions, which come from the consensus statement from Quad AI, that within about a minute or so, we can have a reliable, evidence-based recommendation for the surgeon, for the electrophysiologist. Maybe we could do that right now. Dr. Wilkoff, are you labeled with a penicillin allergy?
I have that label on my chart.
I have not been into your chart, but I can ask you some questions. So I have here, and we'll link to this through the podcast, Pallergy. Pallergy is your pal in the fight against bogus antibiotic allergies and penicillin allergy labels. So this is free. It's open source. This is not for profit, and we'll add a QR code and web link to the podcast. Happy to do that. I've just clicked on that link.
Okay.
It's here on my phone. It looks like an app. It's actually just a website through the RedCap system. And I'm not even going to enter your name. We're just going to go through the questions. Are you ready?
Okay, I'm ready.
All right, let's do it. So here are the questions. What penicillin allergy is this patient labeled with an allergy to? What antibiotic in particular are you?
Penicillin.
Okay, so you think it's penicillin. There we go. I'll click on that. And so the next question is, what other penicillin allergies do you have? Is it only penicillin, or are there other penicillin, amoxicillin, dicloxacillin that you've been labeled
As
with?
far as I know, when I was very small, I had got penicillin, and I really don't even know what kind it was, but maybe that's all there was back then. It's a long time ago.
It's interesting how little antibiotic we now use for penicillin, but okay, very good, that's fine. So are you allergic to cephalosporins? Cephalexin, cefadroxil, cepha anything?
I don't know because nobody's given them to me.
There you go. So we'll click no known allergy there. Here's another one. Since you were told you were allergic to penicillin, have you taken penicillin or amoxicillin or any other kind of cillin?
Not to my knowledge.
Thank you very much. You'd be amazed how often that does happen. Now, do you remember what your allergy is? What happened when you took penicillin?
I was an infant.
You're an infant, so I'm going to, even with your amazing power of recollection, I'm going to say that we do not know.
Yes.
And then the next question says, does the medical record list an allergy that the patient denies? No, you truly believe that you are allergic to this based on what you've been told. Do you recall whether you were seen by a medical doctor at that time? Probably don't recall.
I have no idea. They
Does-
probably got a shot in my rear end or something like that.
maybe so. Patient does not recall. And this was more than 10 years ago, is actually when this happened.
Much more. Yes.
So what we have here, and I'm going to send a shot of this so that people can watch this as well, but we have a recommendation from Pallergy, and it's in bold, it's in yellow, and it's pretty easy to read. I'm wearing my reading glasses. It is okay to use a full dose of any cephalosporin, aztreonam, any carbapenem, or any non-beta-lactam antibiotic. It is also okay to give penicillin after a test dose. So what this means is that if you were to come to the EP lab and we had someone who needed to operate on you, you would be very safe to get cefazolin. On the other hand, if on rare occasion you actually needed penicillin again, we would give you an oral dose first in the clinic and have you flip on your phone or watch TV for an hour, and if you're okay, then you'd be fine for full dose. So that's how quickly we can go through this process. And our vision for this with respect to EP is that, if I'm not mistaken, usually you'll know who this patient is before you operate on them. You should have a conversation pre-op. And whether that's you, whether that's one of your, as you can see, these questions are easy. It could be an MA, it could be an RN who does this, or a physician. It can be done pretty quickly. And my hope is that that can happen preoperatively. Our vision, that primary care does this routinely for every patient in America. The reality, that's going to take a while. So meantime, we want to get this out there to all the surgeons and cardiologists who might need to have access to it. And again, it is free, open source, and I hope helpful.
Yeah, no, I think it could be revolutionary because there are so many labels out there. You say 10%, but sometimes it seems like it's 50%.
At a center like this, it's actually, well, at our hospital, it's closer to 20%.
Okay.
Large centers of reference. That's
So
true.
so it's so common and it's such a useful and inexpensive antibiotic. So I want to ask you another question about this though. I think we mostly dose the medicine wrong too. So I wonder we should get it out there. How should we be using this cefazolin?
Cefazolin should be dosed based on patient's body weight. So for patients who weigh less than 120 kilograms, the dose is 2 grams of cefazolin to finish the infusion within 30 minutes of incision. If it has to be within an hour, that is acceptable, but the closer to the time of incision is right. However, if the patient weighs more than 120 keys, we give a third gram. So it is actually 3 grams for those larger patients. This is similar to what we do for vancomycin with respect to dosing based on body weight. We have not traditionally done this with beta-lactams and cephalosporins, and that's to the patient's detriment. So we really do need to be thoughtful about that based on patient size.
Right.
And how about post-operative antibiotics? I know there's a little bit of debate out there. Any data that suggests that that's useful or not helpful?
Yeah, thanks. It's a great, important question, and we have the answer thanks to Dr. Welkoff, to you, and colleagues here, and nationally as well. That's the PADIT trial, in which postoperative versus usual care, meaning to stop at skin closure, were compared. And in that trial, we did not find a statistically significant difference between those two arms. The suggestion, most patients do not require postoperative antibiotics. I would say there can be individual differences, and I think if at the time of closure or at any point during the case, there's something about that patient that seems different. Maybe there's a smoldering infection preoperatively, etc. Always fine to talk with ID about this, but generally speaking, when the skin closes, so too does the pharmacy, and we're done with antibiotics.
Well, there are so many more things to talk about antibiotics. There's irrigation of the pocket. There's post-operative. We talked about post-operative antibiotics, but second doses and such like that. But I think we've got a really core bit of information here about how to use cephalothin or cefazolin, however we're going to say it, how we're going to use it, how we're going to dose it, and how we can get it to more people. And I really appreciate everybody's coming together for this, just a little glimpse into how we can also collaborate between infectious diseases and the electrophysiologist.
Collaboration is key. ID welcomes that. And in addition, if people are using the tool that we've used today, we would welcome it. It is free, it is open source, and it includes a feedback button at the bottom. There's an ability for you to let us know your experience. If there are problems with it, we would welcome that. We want to crowdsource this and make sure that it is useful in the hands of people who need it.
Excellent. Thanks so much for the time.
The pleasure. Thank you so much for having me.